Ano case natin?
Oh, hi. A 70-year-old man with a history of B-Lymphoblastic leukemia, presenting with anemia and thrombocytopenia. WBC is 6.0 by 10 times 10 to the 9 per liter, RBC 2.90 by 10 times 10 to the 12 per liter, HGB 8.7 grams per deciliter, HCT 27.1%, MCV 88 femtoliter, MCHC 32.1 grams per deciliter, platelet 14 by 10 times 10 to the 9 per liter, and RDW 20%.
Interesting case. Explain.
The CBC data are indicative of a normal WBC count, with moderate normocytic anemia and moderate anisopoikilocytosis, and severe thrombocytopenia. Morphologic examination shows a severe neutropenia and a distinct population of immature lymphoid cells, composed of small to medium-sized blasts, with mostly regular, round, oval nuclear contours, high nuclear to cytoplasmic ratio, dispersed chromatin, inconspicuous nucleoli, and scant amount of cytoplasm. The red blood cells demonstrate echinocytes, elliptocytes, occasional bite cells, teardrop cells, spherocytes, and mild polychromasia. The platelets are normal in size and show appropriate cytoplasmic granulation.
So, the patient has peripheral blood findings consistent with recurrent B-lymphoblastic leukemia/lymphoma.
The CBC demonstrates anemia and thrombocytopenia, and the morphology shows a distinct population of immature lymphoid cells, with very few neutrophils or other leukocytes. So, yes.
Pero, hindi ba common ang ALL sa mga bata?
Yes, ALL is most common in children but may also be seen in adults. Actually, approximately 75% of cases present under the age of 18, and comprise 80 to 85% of leukemias in this age group. Differentiating ALL from AML is important, because the therapeutic regimens differ significantly. The differential diagnosis is based on morphology, cytochemistry, immunophenotyping, and genetics.
Pero mahirap ma-differentiate kung myeloid or lymphoid ang acute leukemia is based on peripheral blood morphology.
True. However, there are some generic cytologic features that may help in that differential diagnosis. Lymphoblasts can be variable in appearance, and it may be impossible to correctly classify an individual cell based on the morphology alone. Lymphoblasts can also be indistinguishable from other types of blasts and lymphoma cells. See, look. The arrowed cells are blast cells, and more specifically lymphoblasts. Lymphoblasts are the most immature cells of the lymphoid series. They are most commonly seen in acute lymphoblastic leukemia and lymphoid blast crisis of chronic myeloid leukemia. These round to oval cells range in size from 10 to 20 micrometer. The N/C ratio varies from 7:1 to 4:1. Morphologically, lymphoblasts are variable in appearance, sometimes even within a single case. In this patient, the lymphoblasts are small to medium in size, with high nuclear to cytoplasmic ratio, dispersed, not clumped, chromatin, and scant, agranular cytoplasm.
As lymphoblasts may be quite variable in appearance, it is often impossible to correctly classify an individual cell based on the morphology alone.
Review of other cells within the sample may help in this regard. Finally, supplemental studies, such as immunophenotyping, are useful to arrive at a definitive diagnosis. Lymphoblasts can sometimes be indistinguishable from other types of blasts and lymphoma cells.
Mukha siyang reactive lymphocyte. How do we differentiate them?
In blood smears, it may be difficult to distinguish reactive lymphocytes from lymphoma cells or lymphoblasts. The most important distinction between these cells is the difference in their N/C ratio. The N/C ratio tends to be low in reactive lymphocytes, while it is typically high in lymphoma cells and lymphoblasts. In addition, reactive lymphocytes are characterized by their wide range of morphologic appearances within the same blood smear. In contrast, while lymphoma cells can exhibit a wide range of morphologic appearances, any individual case of leukemia or lymphoma, such as lymphoblastic leukemia, tends to show a more monotonous population of the cells.